All right, morning, everyone. Thank you for joining us today. It's 7:30 a.m. Central Time, and today is my privilege to uh, to go over the post-ASH updates with several experts in the field. So I will be going over some of the bone marrow failure, the abstracts, and then unfortunately Dr. Ibrahim is not available today. He had some flu, so we will miss him. Dr. Yilmaz will go over the leukemia abstracts that is relevant, and then Dr. Khan, and then lastly Dr. Yilmaz will take over for the lymphoma part. So the abstracts that I will go over is the first four is more of a clinically relevant studies that I will present. And the last two is more of a thought-provoking abstracts that was presented. One of them was the best of ASH, and the other one was from the plenary session. So the first one that I will go over was presented by UK group Daniel Wiseman, the already FDA approved Invoke, the ASTX 727 benefit in the CMML and other MDS-MPN overlap syndromes. This was the first phase 2 multicenter randomized trial results. So as we know, MDS-MPN is very poor outcome disease, and not many specific randomized control trials has been conducted. We know there is only a few approved medication for this condition, and the only randomized control was back in 1990s, where they compared the hydroxycarbamide with etoposide. And in the AZA 001 trial, they only included a handful of CMML patients, and they mainly included the non-proliferative CMMLs, not much the proliferative ones. And in the Dakota trial, even they included the advanced one. The IV decitabine did not seem to be improving the overall survival. Even the progression was better on the treatment arm. And we know the hypomethylating agents, the ASTX 727, oral decitabine with sitazudurin, is the only FDA-approved medication for this condition. And the oral version of this drug has been shown to be as effective as the IV decitabine that was shown in the certain trial. But in the certain trial also, they only included very small population of CMML patients. So this ASTX 727 in MDS-MPN overlap syndrome AMMO trial included any MDS-MPN patients, treatment naive and transplant ineligible, and they stratified to 2-to-1 to ASTX 2727 versus hydroxycarbamide with supportive care. They treated with 6 cycles. Upon clinical benefit, they continued until progression. If the patient did not do well, they transitioned to the hydroxycarbamide with supportive care. And as you can see, they included 13 UK sites. The enrollment was very quick because of the need of the trial for this patient population. So you can see the patient disposition here. It was equally distributed on the treatment versus the hydroxycarbamide arm, and they included mainly the intermediate or high CMML patients. The mutational profiles were very typical mutational profiles, as you can see on the screen. And when they assessed the response by 6 cycle, they did note that the overall survival 54% on the ASTX 727 versus 27 on the hydroxycarbamide arm. And when they looked up the overall survival, both in intention to treat versus the CMML subgroup, they did show the overall survival benefit on the ASTX 727 arm. It was more toxic, and more patients had more myelosuppressive side effects, but the death was not. It did not transition into the overall survival. So the benefit continued to be as an overall survival. And then most of the patient did require dose adjustment, but median number of cycles were 10 on the ASTX 727. So they concluded it's the first randomized controlled trial to show randomized survival advantage in CMML for 30 years. And they proposed, especially in the UK side, ASTX 727 as a new standard of care for advanced symptomatic MDS-MPN. So I think I'm not going to too much comment on this, as the conclusion was very clear for overall survival benefit for the ASTX 727. So next one that I will go over is interesting, provocative kind of results that was presented from Mayo Clinic group, the allo transplant versus the HMA in the VEXAS syndrome patients. So as we know, VEXAS syndrome is pretty much hemato-inflammatory disorders that can present with autoinflammation and progressive bone marrow failure that can lead to substantial mortality. There has been no established standards of care, and there has been several studies that showed the benefit of transplant, and also recently FRENVEX group presented the azacitidine benefit on the HMA, azacitidine benefit on the VEXAS patient that was mainly treated for the bone marrow failure MDS indication. So this group from Mayo Clinic, they wanted to compare the HMA versus the allo transplant, and they did this as a multicenter retrospective analysis. And the outcome of interest was overall survival and glucocorticoid discontinuation. They included several institutions. As you can see here, the age population on the allo transplant was younger than HMA group, and then the time from diagnosis to therapy was longer in the allo transplant compared to HMA group, and the presence of myeloid co-mutations was more common in the HMA group compared to allo group. And interesting enough, indication for therapy seemed to be more for autoinflammation rather than the bone marrow failure when it comes to transplant versus the HMA group. So when they screened this 144 patient with VEXAS syndrome, they did note that 22 underwent to allo transplant and 22 received the HMA therapy. So they basically collected this in a retrospective manner to look at the survival analysis. So you can see on the screen, it did show that even in the restricted comparison groups, the survival benefit on the allo transplant group compared to the HMA, and rate of glucocorticoid discontinuation was more common in the allo transplant group compared to HMA. So obviously, this was also another interesting, they reported as a toxicity that 50%, almost 50% of the HMA group, azacitidine group, did have death with an infection and progressive inflammatory disease and bone marrow failure, and it was much minimum on the allo transplant group with a 20% chronic GVHD, moderate to severe. So they concluded this is the largest transplanted cohort to date with VEXAS syndrome, first formal comparison of allo transplant versus the HMA, and they concluded allo transplant was associated with higher rates of molecular remission, glucocorticoid discontinuation, and improved overall survival with no observed relapses in patients with VEXAS syndrome. So I think it's a little bit provocative because this was not a randomized trial, was only retrospective, and we know the benefit of other, anti-inflammatory agents when it comes to autoinflammatory symptoms of the VEXAS syndrome. I think it's more to come, hopefully, with the more prospective trials. So I'll move to the next one. This was presented by the Germany group under the Hubbard's leadership. So they're adding the L-Thrombopac to immunosuppressive treatment with cyclosporin as frontline therapy for moderate aplastic anemia. This was a randomized controlled phase 3 trial, and they stratified the patients cyclosporin with placebo versus cyclosporin with L-Thrombopac. And then they assessed the superiority of the hematological response with the PR and CR by 24 weeks. As you can see here, the comparison done at 24 weeks, and it was equally distributed. Interesting enough, 50% of them was transfusion dependent with the platelet, but the platelet threshold for transfusion they kept on the 20. So you can see here the 24 weeks response. The overall response was 71 on the cyclosporin plus L-Thrombopac arm versus the 42% on the cyclosporin alone arm. So it did show the benefit of adding the L-Thrombopac to the cyclosporin in the moderate aplastic anemia. And they allowed the patients who did not respond to cyclosporin alone to transition to the cyclosporin L-Thrombopac arm. You can see the cumulative incidence of 3 lineage responses on cyclosporin L-Thrombopac arm. They did better, and this is also another way of looking at transition patients. Even they did not treat it at the first 6 months. Later transition also gained the response. So they concluded L-Thrombopac combined with cyclosporin should be the preferred initial treatment for patients with moderate aplastic anemia. and could become the new standard of care for moderate aplastic anemia patients. So again, no comment. I think it's very clear what they reported, and I think we have been using this agent as a combination for moderate aplastic anemia, but it did show us another way of testing our clinical practice. So the next presentation, the abstract that I want to go over is interesting enough, accepted as a poster. I was expecting this to be a plenary session, but they accepted as a poster. So this was presented by NHLBI group Richard Childs, and they looked up the outcomes of obitopicel expanded umbilical cord transplantation in patients with severe aplastic anemia patients. So as we know, ISTL thrombopath can be very useful, but many patients can have a refractoriness or relapse disease, and there is a high rates of rejection and lower disease-free survival with the alternative donor transplants. Umbilical cord is an alternative, but it's a challenge because of the slow engraftment and high rejection rates due to lower transplanted stem cells. And this study evaluated effectiveness of the obitopicel expanded umbilical cord for severe aplastic anemia refractory to the ISC treatment. So this was a single center phase 2 trial, and they included age from 44 to 60. And the availability of the equal or more than 4 out of 8 HLA-matched umbilical cord unit considered, and the GVHD prophylaxis was tacrolimus with mycophenolate. And outcome was the sustained neutrophil engraftment and overall survival, neutrophil and platelet recovery, and the GVHD complications. So you can see the conditioning regimen on the screen here: course ATG 4 days, and then 2 days of cyclophosphamide, fludarabine, followed by the TBI and the infusion of the umbilical cord expanded stem cell population. So you can see here the results. It's very promising, 94% overall survival even in the 5 years. Neutrophil and then platelet recovery was very quick. And you can see here the very minimum acute GVHD and no chronic GVHD. Interesting also enough that the FDA approved it the same day they presented at ASH. So it's a new treatment modality for severe aplastic anemia patients. It will be interesting enough to see where we will be using this as an agent, whether the refractory patients, or we will pull more for the first-line treatment ineligible for a matched sibling donor transplantation. So this two abstract that I will go over is a very much thought-provoking studies that was presented. First one by the Ömer Abdulwahab's group from Sloan Kettering, and so is a therapeutic potential to use the mitochondrial transfer for MDS. So as we know, mitochondrial dysfunction is a big deal when it comes to in the MDS disease, especially in the ring stereoblastic MDS, and there has been many studies where they showed the feasibility of transferring the mitochondria by different ways to the stem cell pool for promoting hematopoiesis or augmenting the C cell immunity or wound healing. So this also published recently in New England, the mitochondrial replacement therapy for inherited some of the mitochondrial metabolic disorders. So it's been an established way of using in the therapeutic way. And the mitochondrial augmentation is also showed to be useful in the hematopoiesis restoration. So basically, they collect the HSPC cells, and they isolate CD34s, and they mix with the cryopreserved placental-derived allogeneic mitochondria, and then they purify the stem cells and infusing back to the patient. So basically, auto-transplant, auto-infusion. So, and then the preclinical studies-wise, they used the NHT13 transgenic mice, and they collected the stem cell population from this MDS model mice and the regular wild-type mice, and they did the mitochondrial augmentation, and they infused the mice, and they looked up the blood count and flow cytometry with monitoring the survival. You can see here the mice that were treated with mitochondrial augmentation on this screen did better with less leukemic transformation, and they did have the further survival benefits. So for that purpose, they proceeded with the clinical trial phase 1 in the low-risk MDS patients up to 15 patients. And the primary endpoint was safety, and the secondary endpoint was the benefit of transfusion independence. So they depicted one patient at the conference. So this is a 69-year-old male, low-risk MDS, not responding to anything as a conventional treatment. And when they did this mitochondrial augmentation strategy, the patient became transfusion independent. So a conclusion, they concluded the phase 1 clinical trial for MDS patients is ongoing, but there is no safety data issues. So, and there's a lot of things that needs to be alluded, but hopefully we'll see more in coming years. And the last one that I want to go over is also another interesting study that was presented by Kelly Bolton Group. The cyclin D kinase 4/6 inhibition mitigates chemotherapy-induced expansion of TP53 mutant clone hematopoiesis, presented by Ernest Khan. So as we know, genotoxic stress disproportionately depletes the wild-type stem cells and enriched for existing TP53 mutant clone hematopoiesis. So the strategy is, how can we protect the wild-type stem cells from DNA damage? Could we do this by inducing the quiescence during chemotherapy? And we know the cyclin D kinase 4/6 reduces the hematopoietic stem cell cycling that has been shown in the bone marrow, human bone marrow samples. And also we know from the clinical trials that has been done in this small cell lung cancer patient, trilaciclib reduced chemotherapy-related myelosuppression. So, and it did not negatively affect the progression-free survival. So they hypothesized, can we use this CDK4/6 inhibitor on the chemotherapy receiving patients to keep their clonal hematopoiesis stable? And then when they analyzed, I don't know if they did a trial from the beginning or they analyzed the blood samples that was collected, but they collected the samples from the etoposide carboplatin atezolizumab plus trilaciclib versus EPA treated patients, and they matched with the age control, and they looked up their DNA damage response gene expression. So you can see here, they did see that the people who were treated with this chemotherapy, they did increase the DNA damage response mutations. When they looked up the other genes, DNMT3, TET2, and SXL1, it did not seem to be affecting the VAF. So for further analyses, they looked up the other chemotherapy regimens, including colorectal and then the triple negative patients. Again, the same concept. They collected plus trilaciclib versus placebo patient samples, and they analyzed their DDR genes, VAFs, and they did see the chemotherapy regimen who received the trilaciclib did decrease their variant allele frequencies. And then they specifically looked at the TP53 versus the PPM1D, and they did see the benefit in the TP53 and PPM1D more than the CHEK2. So to look in the syngeneic model, they used the mice model by collaborating with Ömer Abdulwahab group, and they irradiated and they looked up this CD45.2 cells, and they looked up the trilaciclib carboplatin versus the carboplatin plus trilaciclib group. As you can see here on the left corner, the mice who were treated with the carboplatin did increase the TP53 mutations, but in the combos, the TP53 was not seemed to be as high as the carboplatin alone group. And they looked up if this effect can be observed in the other CDK4/6 inhibitors by using the palbociclib. Same response, the mutant clones seem to be very slowly growing compared to the wild type. And then, interesting enough, they looked up the wild type TP53 versus the mutant. The mutant seemed to be further cell death in the trilaciclib group compared to the wild type. So they concluded that this CD4/6 inhibitors can induce the TP53 mutant clonal expansion. And they concluded pharmacologically induced quiescence of hematopoietic stem cells may be a promising strategy to reduce therapy-related myeloid neoplasm risk. So again, more to come. We need to see more data on the large cohort of patients, because we have a lot of patients who were treated with different CDK4/6 4/6 inhibitors. So we may need to go back and look at their samples to see if the evidence is also clear there. And then further work needs to be done before we will use it for the purpose of clone hematopoiesis arrest. So I'll stop here and I'll give to Musa for his part.
Thank you, Taha. So I would, there was a plenary AML session, which is not a common occurrence. So that's why I'm going to start with that one from Dr. Amir Fathi, phase 2 randomized study. And then there were quite a lot of good AML abstracts, which I focused on. So I'll be going on some FLT3 abstracts and some menin inhibitors that made it to the oral. So here, this is the first abstract, which is a plenary session. As I mentioned, the paradigm trial is a phase 2 randomized multi-center study comparing aza-ven to conventional induction chemotherapy in patients who are fit for intensive induction. So this was a phase 2 one-to-one randomization. So there are a few important things that we need to know. So they excluded CBF patients from the study, which is reasonably because the gemtuzumab is not included as part of the study. And they also excluded FLT3 mutated patients because these patients receive intensive chemo plus FLT3 inhibitor. And they also excluded NPM1 patients who are younger than 60 years old. That's the patients that we know that the intensive chemotherapy high dose RC works better. And there are some of the subtypes they also excluded. So the 7+3 or CPX, if patient had secondary AML, they got CPX versus 7+3, or the exploration arm is the azacitidine venetoclax, which is the treatment for older patients currently, but they're exploring in fit patients. So here are the patient characteristics. In total, 172 patients. So they were randomized equally to aza-ven to intensive chemotherapy. So overall, they seem to be okay randomized. But if you look to the ELN risk stratification, looks like a bit more adverse groups allocated to intensive chemotherapy, 76% versus 67%. Also, if you looked at the TP53 mutated patients, 18% versus 10%. All in all, this was a randomized study, which is fair from that perspective. So from safety and tolerability, as expected, the aza-ven being a low-intensity chemotherapy, the potential for infection is less. The other complications are less, particularly 60-day mortality was 0% versus about 5%, which we expect to see with intensive chemotherapy. So here are the responses. So the pie chart shows the best. So the blue showing the responses, and the dark blue is the CR, the other shades showing CRH and CRI. The response rates were when we look at the CRC, they were better with the azacitidine venetoclax compared to intensive chemotherapy. So the primary endpoint of the study was event-free survival, so which it met it in primary endpoint. So median event-free survival was about 15 months versus 6 months with intensive chemotherapy. So there are obviously we have to wait for the full publication, but there are a few caveats when you're looking and how you're defining the EFS here, because they allowed aza-ven patients to receive 2 or 3 and perhaps 4 cycles to call them non-responding versus intensive chemotherapy. If they didn't respond, their EFS dropped significantly. So that may factor in from the early parts of this difference. And here is the transplant. So about like 60% of the patients proceeded to transplant in aza-ven arm versus about 40% on the intensive chemotherapy arm. And overall survival was also similar to each other, which proving the fact that for this group of patients, again, these are select patients, not any AML incomers, but these select patients may benefit equally from in terms of survival from aza-ven versus intensive chemotherapy. Obviously, patients who didn't respond to intensive chemo, about 70% underwent the HMA-ven versus patients who didn't respond to aza-ven. About half of them proceeded with 7+3 following their failure. So this study is, again, the results, in my opinion, they cannot be generalized to all AML patients. As you saw the exclusions, I think this is a good study in terms of laying the groundwork for the HMA event, perhaps opening the doors for the triplets and quadruples in patients who are fit for intensive chemotherapy. But we have to really interpret the results very carefully. So patients who are favorable may not really benefit from this. Also, perhaps the better comparator arm instead of 7+3, which personally we don't use often because in younger AML, there's a couple publications, FLAG-IDA-VEN, CLIA-VEN. These triplet chemotherapy backbone with venetoclax combinations has been proven to be more superior results. I think that would have been compared to that rather than 7+3, which is expiring its use. So the next I'm going to talk about. So I sort of summarized each abstract so that I can go through as many as possible. So these are really brief information and some screenshots from the presentation. So the first one I want to talk about is the aza-ven gilteritinib. This is a study presented by Dr. Roberto, one of our fellows. This was an oral abstract. So 30 newly diagnosed FLT3 mutated AML patients, 22 of them were ITD, FLT3 ITD versus 8 was TKD. Median age was 71 years old. The CR/CRR rate reported is 95%. And about 2/3 of the patients achieved FLT3 ITD negativity by NGS testing. So this is a longer follow-up result. This study published in JCU about a year ago. Now there's a longer follow-up. So overall, out of 30, 11 patients relapsed, and median overall survival was 30 months. But when we look at the ITD patients, it was 22 months, and TKD has not reached. So just to give you the background on what to expect, patients who are unfit for chemotherapy, when they have FLT3 ITD, if we give them aza-ven, the expected median overall survival is ranging from 10 to 12 months. So this is sort of doubling that number. I think that's a big progress to see. And similar results have been also shown by a multi-center study. The previous one was single. This was a multi-center study published by Dr. Altman, and this they reported their phase 1 results of aza-ven gilteritinib. Again, the dosing schedules are on the right, but here in this phase 1. Again, their target populations is VIALE-A patient population, which are older patients unfit for chemotherapy. They have looked at VEN 200 versus venetoclax 400. They enrolled 20 and 24 patients respectively to each cohort. And gilteritinib given 80 milligram daily. We know the dose is 120 milligram if you are given as a single agent. With this combo is 80 milligram, which was the same in the previous study I mentioned. So median number of days of venetoclax given is 17 days because they had given shorter days to prevent prolonged cytopenias. So CRC rates was similar to the previous study, about 90%. 30-day mortality was 0%. They haven't provided a decent MRD data because this is really an early report. So just essentially, this is good to see that the previous single institution study has been now is evaluated in multi-center, is applicable and doable, and the study is still looking for, the dosing strategy is still evolving, but it's good to see that the median overall survival has not been reached for this patient population. So hopefully we are going to see more updates. So the abstract I will talk about are menin inhibitors. As you know, this is the field that is a lot of new novel menin inhibitors are being explored, and there are a lot of combinations that are being studied. The first one I would like to talk about is the oral DAC, VEN, and revumenib. As you know, revumenib has been approved by the FDA for KMT2A and NPM1 mutated AML. So in this study, they report 21 patients. They are unfit, median age 70. 14 of them had NPM1, 7 patients had KMT2A. CRC rate was about 80%, and flow negativity rate was 81%. Among patients who had NPM1 mutations, the NPM1 MRD by NGS was was 80%. And two early deaths, one septic shock, one DAH, and about the third of the patients proceeded to allogeneic transplant. Median overall survival is not reached. Again, this is one of the other early studies that we have to see with the more longer follow-up, with more patients enrolled, how it's going to pan out. But I think the one thing that I took from this abstract is that the early deaths, because of the potential QTc prolongation of the revumenib, had the investigators have used more cephalosporin-based prophylaxis rather than levofloxacin, which would have prevented maybe some of the infectious complications, which I believe they have mentioned Pseudomonas bacteremia, ESBL bacteremias in some patients. And the next abstract is presented by Dr. Robos, ziftomenib azaven in NPM1 mutated AML. So the ziftomenib has shown more activity, better activity on NPM1 with less toxicity. That's the study that they did. 600 milligrams zifto, ven, and azacitidine, and they enrolled NPM1 mutated patients. As you know, again, this is just about a month ago, the ziftomenib approved as a single agent NPM1 mutated AML. So this is again unfit patient population, median age 75, and the CRC rate was 86%. And best molecular MRD improved over time. So patients from after cycle 1, the NPM1 MRD negativity was 6%. It went up to 90 to 100% after the third and fourth cycles. And median time to ANC recovery was about 36 days, which is perhaps a few days longer than the aza-ven that you would expect. But these are phenomenal results, I think, in my opinion. Essentially, with the short follow-up they have, the median CR duration, median OS has not been reached, but patients particularly those are the ones who are getting to third and fourth cycles, they are clearing their MRD close to 100%. And also on the right corner, I put the figure of the planned clinical trials that with the ziftomenib, there will be a randomized study, ziftomenib versus aza-ven versus aza-ven placebo. So triplet with the placebo in a randomized study. Also, they are going to be looking zifto with intensive chemotherapy versus placebo. So they are planning to enroll about 1,300 patients in these phase 3 randomized studies, which will be interesting to see the outcomes. So a couple more about the other studies that I like to talk about. Enzomenib monotherapy, presented by Dr. Dower. So they have looked at they have achieved recommended phase 2 dose for the KMT2A patient population, which is 300 milligram BID, and in these relapse refractory patients, the CRC rate is 60%, and median remission duration is 12 months, which is actually pretty good numbers with this targeted single agent. NPM1 mutated, they treated 21 patients, the CRC rate about 44%, but the dose of optimization is still ongoing. So there's like 200, 300, 400 BID doses that are still being explored, but that is another promising regimen in this space. Also, Dr. Was presented enzomenib not as a single, but aza-ven, but in the relapse refractory KMT2A and NPM1 mutated patient population. Similar triplet designs that I mentioned earlier. So they had 18 patients with KMT2A and 22 patients with NPM1. And the CRC rate they reported is about 50%, and 10 patients still on therapy, 6 patients proceeded to allogeneic transplant. So this is again another active triplet regimen which allows patients to proceed to allogeneic transplant, and more results to come. So this is ICT-01, which is a gamma delta T cell engager. So this is a monoclonal antibody that engages gamma delta T cells. And this is a study that they have evaluated 2 doses, 10 milligrams versus 75 milligrams, which is given every 4 weeks, along with azacitidine and venetoclax in patients with newly diagnosed acute myeloid leukemia. On the right top, you can see they allow patients newly diagnosed AML 75 or older and who are unfit for intensive chemotherapy As you can see, the high dose and low dose, but they have decided the recommended phase 2 dose is the low dose. And as you can see from the result on the low dose, they have had 41 patients versus 16 patients, but the patients who had low dose had a higher response rates and they had better tolerability. Now they are planning a randomized study using the low dose of gamma delta T cell engager along with the placebo. Thank you very much.
Well, thank you all so much. I appreciate your early attention this morning here. It's my pleasure to do the multiple myeloma portion of the ASH review here. And this was another great year for myeloma in general. There were dozens of really phenomenal abstracts here. There's no shortage of groundbreaking work. And so I could not claim that these are necessarily the top abstracts because they're subject to opinion. There was so much great work. But here are a couple of interesting ones. And I think one that cannot be ignored was the Majestic 3 trial. So this was a phase 3 trial that was involving teclistamab, studied in combination with daratumumab. So just some background. So teclistamab is one of the 4 bispecific antibodies currently available for multiple myeloma. It targets an antigen BCMA, and right now it's used for a very heavily relapsed refractory population. And this trial was one that was exploring the earlier usage of this, moving it up in terms of lines of treatment. So this is a phase 3 study, again, looking at the combination of teclistamab with a more conventionally used drug, daratumumab, in comparison to an investigator's choice of another DARA-based regimen, particularly dara-Pomdex versus dara-Velcade-dex. This was presented by Dr. Mary V. Mateos and was an oral. So this is the study schema. These are patients with 1 to 3 prior lines of treatment, including a proteasome inhibitor, lenalidomide. They could not have had a previous BCMA agent, and they could not have been immediately refractory to an anti-CD38 monoclonal antibody. The dosing scheme was largely dictated by the way that the teclistamab was given with step-up dosing, and then the daratumumab dosing was given to essentially match that. And in terms of the comparator group, while both dara-Pomdex and dara-Velcade-dex were options by, again, investigator's choice, the vast majority were dara-Pomdex, 91%, as you can see there. So they had roughly 291 patients in the dara-Tec group, 296 patients in the dara-Pom, dara-Velcade-dex group. And the primary endpoint that they sought was progression-free survival with several secondary endpoints, including overall survival. And in terms of baseline demographics, these patients were a little bit younger than what we typically see in practice. Their median age was 64. There was a good balance between males versus females. They had a reasonably good spread of racial diversity there, quite a bit of Asians that were represented. In terms of their performance status as measured by ECOG, most were 0 to 1. There was about 8% in each group who had ISS stage 3 disease. Otherwise, the majority had stage 1. The presence of soft tissue plasmacytomas was 14% in the Tec-Dara group and similar in the dara-Pom, dara-Velcade-dex group. And high-risk cytogenetics was balanced between the two at roughly 35-36%. And in terms of prior lines of treatment, the median in both was just 2. Prior transplantation was for the vast majority in both, over 70%. And patients had triple class exposure. In terms of being refractory to the last line of treatment, it was 86 versus 85% in Tec-Dara versus the dara-Pom, dara-Velcade-dex. And this was overall deemed to be quite similar. And so what did we get? And this was really where we saw a striking difference. So in the Tec-Dara group versus the dara-Pom, dara-Velcade-dex group, the 3-year progression-free survival was 83% versus just 29.7%. So a marked difference. This is highly statistically significant. The hazard ratio is 0.17. And this median follow-up had extended to that point to demonstrate really a marked difference between the two groups there, supporting the use of an earlier bispecific here in comparison to what we would consider a more conventional triplet in myeloma. And in looking at the subgroup analyses of the progression-free survival, looking at the breakdown from age to prior anti-CD38 treatment, prior lenalidomide treatment, the performance status, whether the choice of regimen was the Dara-Pom-Dex versus the Dara-Velcade-Dex, prior lines of treatment, all of those favored the Dara-Tech group. So there's no Sampson's paradox here in all ways that the data was sliced, which has its own statistical issues, granted. It did continue to favor the novel combo of Dara-Tech here. And then looking at the secondary endpoint, there was a slight crossover that happened early on, and this is explained likely by the fact that it tends to be hard to show overall survival differences in multiple myeloma currently. But as data matured towards the 36-month mark, we saw also a notable overall survival difference, that the 36-month overall survival rate was 83% in the Tech-Dara group versus 65% in the Dara-Pom-Dara-Velcade group. And the hazard ratio is 0.46. And again, this achieved high statistical significance, again, then demonstrating that overall survival and progression-free survival are better supported by the combination of teclistamab daratumumab rather than a conventional daratumumab containing regimen. And 83% of the patients then alive at 3 years, really a remarkable achievement by this combination. And in terms of then overall response, so we saw that the vast majority of responders of the Dara-Tech group were a VGPR or better. And of those, 87% who had achieved that, 82 had in fact achieved a CR, a complete response. In comparison to the Dara-Pom, Dara-Velcade-Dex groups, only about 57% had achieved a VGPR, and of that, roughly 32% had achieved a CR. So a complete difference in what we see in terms of response. Now, interestingly here, the median time to the first CR was actually similar between the groups. So it was about 6.9 months in both cases, in the Tech-Dara versus the Dara-Pom, Dara-Velcade-Dex groups. But what the data then suggests is that once it is achieved, it is held on to far longer in the case of the bispecific Dara combination. And in terms of then safety, so CRS was something that was cued in on here. And in general, it was mostly just grade 1 that was seen. And the grade 2 events were low, 15.9%. No one had anything beyond that in this trial. The rates of neurotoxicity, ICANS, was also low at roughly just 1% in the Tech-Dara group. And in general, those that led to treatment discontinuation were very similar between the two, of roughly 5% in the Dara-Tech group and 5% in the Dara-Pom, Dara-Velcade-Dex group. And the serious adverse events were similarly between the two. Looking at then infections, this is a particular concern with really any BCMA agent, as we have seen now in all the T-cell redirecting therapies, whether it is a bispecific antibody of one company versus another or CAR T therapy, we worry about infections, so that was cued in here. While the infectious rate was higher in the Tech-Dara group compared to the Dara-Pom, Dara-Velcade-Dex group, over time that did attenuate and became similar between the two. Looking at the length of time of 30, and there's a little bit of perhaps an immortal time bias there, and some acknowledge that 8.1 to 8.8% in comparison Tech-Dara versus Dara-Velcade-Dex, Dara-Pom-Dex, quite similar rates, but acknowledging that early on we did see a greater rise in these infections in the Tech-Dara group. And so that supported the earlier usage of a bispecific. And that same theme, then I'd like to present then the Immunoplant study. This is an earlier phase study. This is a phase 2 trial, largely based out of the University of Miami, that looked at the use of linvoseltamab as a consolidative strategy. So linvoseltamab is yet another bispecific antibody, multiple myeloma, also targets BCMA, and it's kind of the newest kid on the block in that regard. It is actually the third BCMA CD3 bispecific antibody. And in this trial, again, a phase 2 study, largely based out of the University of Miami, this was presented by Dr. Kazanjian. They looked at the use of linvoseltamab as a consolidation after a conventional induction regimen for those patients who did not achieve MRD negativity. So with the schema here, it becomes a little bit easier to see that after a patient had been given for newly diagnosed myeloma, a conventional standard of care induction regimen, they would undergo then an assessment of their restaging. And if they achieved a VGPR better, but were MRD positive, that allowed them to be potentially enrolled into this trial. And then they were given linvoseltamab, cycles 1 to 4, up to then 6 cycles, with a repeat assessment in the middle. So after 1 to 4 cycles, they had another MRD assessment, and this was looking at 10 to the minus sixth. And if they were negative, they moved on to observation. And if they're positive, they got another 2 cycles of linvo, and then again had a repeat analysis. What they were looking for here was the MRD conversion rate at the 10 to the minus 6 level, so clinically relevant for what we do in practice. And then secondary endpoints include sustained MRDs and PFS and OS. And in terms of the baseline demographics, so this was not an enormous study. This was roughly 25 patients here. This is the median age was about 62. Over a third of them were over the age of 65. There were a good chunk more males than females in this case. Number of females was 32%. Performance status, they all had PFS. Had performance status of 0 to 1, 76 to 24%. A good representation of racial and ethnic makeup of blacks being 16%, Hispanics being 44%, largely reflecting then the underlying Miami population. And in terms of disease characteristics, there was a preponderance of the IgG isotype, as would be expected, with then IgA and light chain, and they actually had an IgD myeloma case in this study as well. And in terms of FISH and cytogenetics, they saw roughly a third being high risk and then the soft majority being standard risk. And the regimens that people received as newly diagnosed was the plurality DARE-RVD or KRD, and then followed very closely by DARA KRD. So these follow what we conventionally see in practice here. And in terms of the MRD rates, then for those who had achieved at the study start, those who had also an SCR were 16%, those who were VGPR were 84%. And in terms of just some of the other specifics, this was dosed according to the conventional linvoseltamab plan with the step-up dosing and then spaced out from weekly to every other week. They did have required prophylactic treatment here since this was largely geared to be an outpatient regimen. And so they did receive preemptive tocilizumab and dexamethasone to try to mitigate what are felt to be the early toxicities with potential CRS or neurotoxicity. And so the hospitalization was actually only brief at the beginning and then optional should it be needed in the mid-cycle. And so the patient disposition here, 28 were screened. Those who actually received treatment were 25 here. And currently who are in the study and then dictated the data here was 24 and one was off due to issues of compliance. And the median follow-up here was about 7.2 months. So what they saw then was with those patients then, those who then received the linvo as consolidated treatment with just 4 cycles there, they achieved MRD negativity and then up to the 6 in total 100%. So for those who then had consolidated linvoseltamab, up 4 to 6 cycles in total could be declared to convert from MRD positivity to negativity at a rate of 100% when achieving a VGPR or better with conventional induction treatment. And no patients had CRS or ICANS in this. There were no deaths. There was only one grade 3 event, a peritonsillar abscess, which was felt to be likely unrelated. No grade 4 issues, and just dose delays due to some infection-related issues in 6 patients at the time. And so they tout that this is a potentially very successful consolidative strategy for those patients who need a little extra oomph after induction treatment who still maintain some low-level disease in the bone marrow. With the prophylactic use of Toci-Dex, this was very feasible, mitigated untoward side effects, and again, converted them from MRD positivity to negativity at 100%. And this is still a very much an ongoing study. 12-month and 24-month evaluations are upcoming, and so we're looking forward to seeing some sustained MRD results based on that, which then could be very practice-changing going forward. And so then the next trial I'd like to present here is one where it feels like the future is now, and this is the in-MyCAR study of KLN 1010. So this is an early phase 1 study of a novel CAR T construct. This is actually a gene therapy that creates then an in vivo CAR product. So in comparison to ex vivo, where we collect T cells, they're manufactured into CAR T cells and then reinfused into a patient, this was using a lentivirus to deliver a gene that would make one produce CAR T cells. And this is an early study, only included roughly 20 patients, and really what they focused on here was the first 4 patients to just demonstrate its efficacy and some of its early safety data. And essentially, these are patients, largely they were treated in Australia. This was presented by Dr. Ho. They had to have relapse refractory disease after 3 lines of conventional treatment with a proteasome inhibitor, an immunomodulatory drug, and anti-CD38 monoclonal antibody with favorable performance status and favorable marrow and organ function. And these shows the baseline demographics of the first 4 patients. They all had IgG disease, except for one who was IgM. They all had prior auto transplants. They had a typical refractory picture. And in the swimmer's plot of the first 4 patients there, they all achieved MRD negativity. And what they then show is in terms of some of their kinetic data, they see the CAR T successfully expand in all 4 patients without lymphodepleting chemotherapy. This happens on its own. And in looking at flow cytometry at what the actual, what is composing of the ALC, they can successfully declare these to be actually CAR T cells based on their markers. There was minimal dexamethasone used in this case. There was no clinical sequela related to the lymphocytosis that they experienced in the LD expansion, in the lymphocyte expansion. And this was similar to other CAR products. So particularly using some of the data from the CAR-T trials with cilta-cel, they saw that there were similar numbers in terms of this Cmax of the vector copies here between these patients. So noting that the in vivo strategy in, again, this very small study with very select patients is successful in demonstrating CAR T can expand and have clinical efficacy. And in terms of then safety data, they remarkably did not see neurotoxicity, and they saw only minimal cytokine release syndrome of only grade 1 to 2, nothing grade 3 or beyond. So this is really quite different than what we see in conventional practice. Now, granted, they did use dexamethasone tocilizumab here, as I mentioned a moment ago, but this did mitigate then untoward side effects. And in terms of other things that they then saw, there were some infusional reactions that were seen in most of the patients, some hematologic abnormalities that were mostly grade 1. And in terms of grade 3 events, in 1 patient there was anemia, 1 patient there was thrombocytopenia, and in 2 there were neutropenia. And this was of limited duration. And of course, the study is ongoing, so we'll see how this actually plays out. And in general, this is felt to be better tolerated than ex vivo conventional CAR T products. So again, supporting a new novel delivery method for CAR T treatment to a number of patients. And so they conclude that this would be, potentially very successful. Again, 100% MRD negativity rates here. And while this continues to go on, the durability response is, of course, a priority to evaluate. It shows remarkable potential in practice. From a final study, just running through this then very fast, this was just a subgroup analysis of the determination trial. This was a phase 3 study that was published in 2022, which looked at the newly diagnosed patients with myeloma who had been given RVD alone versus RVD with transplant. And this was, again, a subgroup analysis looking at those with Duffy null phenotype, noting that those patients have some peculiar inflammasome and clinical phenotype matters behind them. And in that, the background hypothesis was that there are, while in epidemiology data, we've seen that African Americans have had lower and reduced outcomes in myeloma in general, when things such as transplants and triplets are controlled for, we actually see that they do just as well, if not better. And so this was another look at that. So in one way, enriching for the African American population and examining if that is still then seen. And here you could see that there was enrichment in the African American population. And in looking at, just jumping to here, in the pooled PFS study, that the Duffy null status attenuated the actual treatment of RVD alone versus RVD with transplant. And in then the breakdown here, you can see that potentially they still did actually better regardless of treatment in this subgroup analysis. So pointing to some interesting data here. With that, I will skip over this last one and thank you all for your time.
All right, so let me get started. Good morning, everyone. I will be going over the ASH lymphoma updates. There is a lot to go over. I tried to shorten it by selecting only 4 abstracts for in-depth discussion. I mean, that is not going to be even in-depth discussion because of the time constraint. All right, but before we get started with the abstracts, there have been 3 FDA approvals within the last month in lymphoma, so I will just briefly mention those. And then again, 4 studies that I selected from the ASH abstracts. There was multiple very good abstracts in the field of CLL, so I'll mention 2 of those. There was a whole session regarding bispecific antibody use in elderly, unfit, untreated diffuse large B-cell lymphoma patients. I selected 1 from that session. And obviously, as expected, there were a lot of studies utilizing bispecifics in the frontline and relapsed refractory setting in follicular lymphoma. And I will be talking about rituximab EPCO study in newly diagnosed follicular lymphoma. There's a typo here. This is not relapsed refractory. It is for newly diagnosed patients. So briefly regarding the FDA approvals in November, the epcoritamab, lenalidomide, and rituximab, which we briefly call EPCO R-square regimen, got approved in the second line and beyond follicular lymphoma. We didn't have a lot of treatment options in second-line follicular lymphoma for the longest time. Earlier this year, Tafa R-square got approved in this space, and now we have the EPCO R-square. It's a time-limited treatment of 12 cycles. The outcomes are so good that it makes you question whether 12 cycles of lenalidomide is required in this regimen. A simultaneous approval was the traditional approval of epcoritamab monotherapy in relapsed refractory follicular lymphoma in third line and beyond. This was an accelerated approval before, so it just became a traditional approval. On December 3rd, FDA approved pirtobrutinib in relapsed refractory CLL after covalent BTKI therapy in the second line and beyond. Again, this was also an accelerated approval before it became traditional. And then on December 4th, we got the very first CAR-T approval in relapsed refractory marginal zone lymphoma, liso-cel in the third line and beyond. Okay, so CLL17 study is a very well seamlessly designed, multi-center, randomized, 3-arm, non-inferiority study out of Europe led by a German CLL group. There were 909 patients randomized into 3 different arms. Eligibility criteria included adult patients with untreated CLL, regardless of age and their genomic risk. Roughly 8% of the patients had a TP53 alterations, such as deletion of 17p or p53 mutations, and little over half of the patients had unmutated IGHV, both of which are associated with poor outcomes in CLL. Intervention arms included fixed duration of venetoclax and obinutuzumab, which is 12 cycles of time-limited therapy, as in the case of CLL14 study. The second arm was fixed duration of venetoclax and ibrutinib for a total of 15 cycles, the first 3 cycles being ibrutinib monotherapy leading, followed by 12 cycles of combination. And then the third arm was the continuous ibrutinib monotherapy. On the same day of the abstract presentation, the study got simultaneously published in New England Journal of Medicine, which speaks for itself regarding the quality of the study. This is the Kaplan-Meier curve for the progression-free survival. The median duration of follow-up was almost 3 years in the study. So we're looking at the 3-year PFS outcomes in all 3 different groups, which looks pretty non-inferior to each other. And you can see them numerically on the slide. The 3-year PFS was 81% in VO versus 79 in VI versus 81% in ibrutinib monotherapy. outcomes were similar in IGHV unmutated patients. There was a trend towards improved outcome in TP53 altered patients with ibrutinib-containing regimens, not surprising based on the prior studies in the field. This was not statistically significant because I think it was a numbers issue. Number of patients with TP53 alterations were small in the study, which makes sense because this is a frontline study. In terms of the safety, as anticipated, early treatment discontinuation was pretty common in the ibrutinib monotherapy arm because it was a continuous therapy. Though severe adverse events were more common in VO arm than the ibrutinib-containing arms, and that was mainly due to infections and cytopenias with the addition of obinutuzumab. Serious cardiac events, as expected, were more common in the ibrutinib monotherapy arm, was much lower in the VO or the VI treatment arms. This study is practice changing for a lot of people. What we can do, at least my take moving forward from the study is that in a non-P53 altered patients, wild-type patients, VO is a really decent regimen, unless you're not really concerned about the bit of a frailty of your patients from the recurrent infections and cytopenias and hospital admission standpoint. VI is a great choice as a time-limited therapy for TP53 altered patients. And patients who receive VI in the front line can benefit from covalent BTK inhibitors in the subsequent lines of therapy because this is just a time-limited treatment. One big criticism for the US patients in the study is that we no longer use ibrutinib in the frontline treatment of CLL and in the treatment of CLL in general. We use either acala and zanubrutinib because they have much better toxicity profile. So it's unclear if outcomes would change if we use acala or zanubrutinib instead of ibrutinib in the study sort of scenario. The ongoing MAGIC trial hopefully will answer this question in the next few years. The MAGIC trial is a multi-center phase 3 study of acala-ven versus ven-oben, so it will be interesting to see what that shows. The next study that I will be talking about is the Bruin CLL14 study, which is a phase 3 non-inferiority study of over 600 BTKI naive, newly diagnosed or relapsed refractory CLL patients. This is a bit of an unusual design because they're including both newly diagnosed and relapsed refractory CLL patients in the same study, and then they're utilizing overall response rate as a primary objective of the study, which is, I'm not sure how relevant in CLL. You mainly look into PFS, not the overall response rate. It doesn't matter whether your patients have PR or CR in most cases, unless you're really trying to achieve a deep remission with a time-limited treatment. Another criticism to this study was that median duration of follow-up was short in relapse refractory and also in the treatment naive groups, 18 months versus 22 months. In the relapse refractory group, median lines of prior systemic therapy was 1, so it wasn't a very heavily treated group of patients. Regarding the safety, as expected, there were fewer dose reductions and discontinuations related to adverse events in the pirto arm, but overall rate of infections were not really significant between the two arms. As expected, grade 3 and more neutropenia is a bit more with ibrutinib, but the grade 3 and more thrombocytopenia was similar in between both groups. At the same time, with the oral presentation, this study got simultaneously published at the JCO, though I am not sure if it is practice changing. So the study met its primary endpoint. The overall response rate was higher with pirtobrutinib as opposed to ibrutinib in the all intention to treat population, and it showed a non-inferiority of pirtobrutinib to ibrutinib in the ITT population. If you look at the PFS in the treatment naive population, this favored pirto, but this was an exploratory endpoint in this study. We need to make a note of that. And then another problem in terms of the practice changing aspect of it is that using pirto in the front line or as a first line option in BTKI naive CLL could create potential sequencing issues down the line because there's no data supporting the efficacy of covalent BTKI therapy after non-covalent BTK inhibitor therapy. And there was a recent blood publication out of Dana-Farber exploring the resistance mechanisms in pirtobrutinib-treated patients. You see a lot of mutations in these individuals that are seen with non-covalent BTKI therapy. So it's a bit of a concern here. Actually, other CLL abstracts, again, there was a lot going on with CLL in this year in ASH. I don't have the time to go into the details for all the significant studies that were presented at ASH, but a few noteworthy are the Cadence study, which is a early phase study of BTK degrader in relapsed refractory CLL. This is B1's BTK degrader. Outcomes were great in a very heavily treated patient population. And then they presented results from the phase 2 study of luspatercept, which is another selective BCL2 inhibitor out of China. And then there was this phase 1 study of rocatinib, which is a covalent and a non-covalent BTK inhibitor in relapsed refractory CLL, which was pretty interesting. I'll move on with the R-POLA-GLOW study in DLBCL. This is a single-arm, multi-center, phase 2 study of newly diagnosed elderly unfrail DLBCL. The study included a total of 80 patients. Median age was 80 in this group. Most of them had advanced stage disease. Almost a third had ECOG of 2, and most patients had IPI 3 or 3 to 5, which is high intermediate to high risk disease. And 91% of patients in the study were deemed medically unfit or frail per simplified geriatric assessment. Despite that, 80% of all patients completed therapy without any treatment interruptions or discontinuations. You can see the study design below on the slide. Every patient was given the steroid prephase for tumor debulking. They did not elaborate as to what kind of steroid that they gave and how many days, what was the dose. That part is a bit of a mystery, but the cycle 1 started with a dose of rituximab, polatuzumab, and there was a 2-dose ramp up for glofitamab on cycle 1, day 8 and day 15. All patients receive R-POLA-GLOW combination for a total of 6 cycles, and then the remaining 6 cycles of therapy was glofitamab consolidation alone once every 3 weeks. So it was a total of 12 cycles of time-limited therapy in frontline elderly frail DLBCL. The treatment-related mortality was 4%, and all of them were due to infections. Grade 3 to 5 infections appeared in 22% of the patients. In terms of the CRS and ICANS, the results were, I think, pretty good from the CRS and ICANS standpoint. There were no grade 4 or 5 CRS. There was only just one grade 3 CRS case. Otherwise, most of them were grade 1 to 2, pretty manageable. There were only 3 patients with ICANS, 2 grade 2 and 1 grade 3. Considering this elderly frail population, I think these outcomes are pretty good. The study showed that certain patients had complete metabolic response conversion from partial responses after cycle 6 during the glofi consolidation phase. The reason of this is not very clear. They did not really elaborate because they did not have the circulating CT tumor DNA results to supplement their conclusions. It's not clear if these conversations are purely from the benefit of glofi consolidation, or there were some patients with false positive PET scans due to inflammation induced by the glofi and the treatment in general, and those sort of calm down over time. We don't know the answer to that. And then another question, another criticism to this study is that what is the role of rituximab in this combination? Is it really adding in terms of efficacy? Is it making the side effects a bit worse from the infections and cytopenia standpoints? We don't know. But if you look at the 1-year PFS, which is almost 85%, and that is impressive. There were many other Similar concepts in elderly unfit DLBCL. There was a whole session dedicated to this group of patients in the frontline treatment setting. There was Morning Sun study, which is a phase 2 study of mosun monotherapy, again in untreated elderly unfit DLBCL. There was a phase 2 study of epcoritamab monotherapy in a time-limited fashion, and then there was EPCO-R mini-CHOP. So how do you pick and choose? I think we will need to have phase 3 data here to see which regimen will be the winner eventually, and to get answers to some of the unanswered questions in the setting. And the last study that I'm going to be presenting is rituximab plus epcoritamab in untreated follicular lymphoma. This is a very small multi-center phase 2 study. The reason that I'm presenting this study today is that I think it's a really clever design, and that's really what I would do if I were to design an untreated a frontline regimen by specific base in untreated follicular lymphoma. We've had multiple other studies in this space before. There was bispecifics with BTK inhibitors. There was EPCO-R squared, but do you really need to combine bispecifics with something else in untreated follicular lymphoma? Do we really need to intensify treatment? Because outcomes are already pretty good on untreated follicular lymphoma, even with standard of care like R-square and PR alone. So this study utilized rituximab pretty much only for debulking of the tumor burden initially. Every patient in the study met the modified Gelf criteria prior to enrollment, and almost a third of them had bulky disease. So these were high tumor burden patients. About 20% of them were grade 3A disease, which tends to behave a bit worse than the rest of the low-grade follicular lymphoma, and over half of the patients had high Philippi score. Rituximab was given once a week for a total of four doses only. The rest of the regimen was basically essentially epcoritamab monotherapy. They considered the cycle 1 as a 6 weeks duration, and the remaining cycle duration was 4 weeks for each. The initial, I believe, 2/3 of the patients, the first 26 patients, received only 2 step-up doses during cycle 1, but they did have this 23-hour inpatient observation after the first full dose of epcoritamab. Starting in patient 27 through patient 35, they added a 3rd step-up dose to cycle 1, and they eliminated inpatient observation. But the rest is the epcoritamab was given once a week for the first 3 cycles, so 12 doses of once a week administration, followed by once every 2 weeks for a total of 9 cycles of time-limited therapy. In terms of the safety outcomes, as expected, CRS was less common in patients who received 3 step-up doses as opposed to patients who received 2 step-up doses. Grade 3 infections were relatively uncommon, only in 9% of the patients. Only 4 patients discontinued treatment early due to recurrent infections out of 35 patients total, and there was no treatment-related death. There was no ICANS in the study, and there was only grade 1 and 2 to CRS. Going back to the safety, this is you can see the plot on the right side of the slide, which gives you more detailed information regarding the safety, but I didn't have any major concerns regarding the safety of this study. If you look at the 1-year PFS rate, it was 91%. Sorry, it was 97% 1-year PFS, and the complete metabolic response rate was 91%. The only non-responder actually had histologic transformation, the large B-cell lymphoma, at first response assessment, and that's why CMR rate was not 100% in the study. So that's all I needed to talk about the lymphoma abstracts from the ASH 2025, and I hope this was helpful. Thank you.
Thank you, Elif and Adeel and Musa, for making these presentations and abstract reviews ready in a day or two. Okay, great. So we'll adjourn here then. Thank you again for joining us. I hope everyone will have a wonderful 2026 upcoming year. Thank you.